Hello everyone, I am Man Gozun, one of the resident physicians from University of Hawaii Internal Medicine Program, and I'm here to present a case report of acute pulmonary embolism in AIDS with disseminated mycobacterium avium complex infection. Today, we're going to learn about the incidence and recognize the risk factors of pulmonary embolism in the HIV-infected population, identify the management for pulmonary embolism in patients with AIDS, and understand the need to explore the relationship between disseminated MAC infection in HIV and thrombosis. This is a case of a 33-year-old male with past medical history significant for a recent diagnosis of AIDS who came in for shortness of breath. 4 months prior to admission, he initially was found to have a viral load of 249,000 and a CD4 count of 22. A diagnosis of AIDS was then made. At that time, he was started on antiretroviral therapy and pneumocystis carinii pneumonia prophylaxis. His condition was complicated by pancytopenia, with evaluation revealing extensive mesenteric lymphadenopathy on CT abdomen. Bone marrow biopsy and flow cytometry were negative for monoclonal B-cell expansion, ruling out lymphoma. Bone marrow and blood cultures eventually yielded mycobacterium avium complex consistent with disseminated MAC infection. He presented at the emergency department for new onset shortness of breath, accompanied by generalized weakness and unintended weight loss of 33 pounds in less than a year. Vital signs are pertinent for hypotension, tachycardia, and tachypnea. He was chronically ill-appearing, pale, cachectic, with normal heart and lung sounds on examination. Initial investigation showed a viral load of 30, CD4 count of 141, hemoglobin of 5.6, white count of 21.3, and a normal platelet count. Chest X-ray showed mild retrocardiac capacities. And as you can see here, the first picture shows us the CT abdomen that was done 4 months prior to admission, showing extensive mesenteric lymphadenopathy. The second picture shows us the repeat CT abdomen that was done upon admission with a yellow bracket depicting the new massive splenomegaly and the white bracket again showing the mesenteric lymphadenopathy. The third picture shows us the chest CT angiography with white markers showing us the pulmonary embolus in the right lung. Therapeutic anticoagulation with heparin was then started. Despite resuscitation with normal saline and blood transfusions, he required norepinephrine for hemodynamic support. Vancomycin and ceftriaxone were started for sepsis of unknown source, as well as clarithromycin and ethambutol for his disseminated MAC infection. The patient improved and the remainder of the hospitalization was uneventful. Pulmonary embolism in the HIV-infected population is uncommon, with recent literature describing an incidence of 0.26% to 7.6%, with a median age of 43 years old upon diagnosis. AIDS, CD4 count of less than 200, and active opportunistic infections like disseminated MAC infection put patients at a higher risk, which are all present in our case. Other risk factors described in other literatures include HIV-related malignancy, smoking, and dyslipidemia. Management includes anticoagulation in combination with antiretroviral therapy and concomitant treatment of other HIV-related complications. In our case, he was treated with clarithromycin and ethambutol for disseminated MAC infection. While an association between mycobacterium tuberculosis and thrombosis is known, possibly due to increased expression of tissue factor, to our knowledge, this relationship has not been explored in non-tuberculous mycobacterial disease. Another case report described a patient with disseminated MAC infection presenting with disseminated intravascular coagulation, suggested that hypercoagulable state could be from elaboration of bacterial products like glycopolysaccharides and neutrophils. It is possible that similar mechanisms exist in this population that may explain our patient's presentation. Clinicians should always keep pulmonary embolism in mind in patients who have shortness of breath unexplained by pneumonia or other common etiologies. As we all know, pulmonary embolism has significant mortality as high as 30% if left untreated, and patients may suffer and die if misdiagnosed. That ends my presentation. Thank you.